Hello students, I am Dr. Rana, consultant gynecologist at Usha Bansal Nursing Home.
Question is, all of the following may be observed in a normal pregnancy except options are fall in serum iron concentration, increase in serum iron binding capacity, increase in blood viscosity, increase in blood oxygen carrying capacity. So this question is from the topic physiological changes in pregnancy, how a lady adjusts itself to the pregnancy changes. Okay, so these are some basic things. So a doctor should know, a gynec should know which things are normal. Okay, so how to interpret that normal things and not to consider themselves as a diseases. So these are the basic things which are much expected from you all. Okay, so let's see physiological changes in pregnancy. First of all that hematological values, all that values that are increased on the blood reports, all that hematological values, because there is increase in the blood volume by 45%. Because there is increase in the blood volume by 45%, the increase in the blood volume is by 45%. Okay, and the increase in the plasma volume is by 45%. Because the blood volume increases, so the plasma volume increases. Okay, so the plasma volume increase, and this increase in the blood volume and plasma volume is due to the increased water retention. There is almost 6.5 liter water retention in the pregnancy. That is why the blood volume is increased and the plasma volume is increased by 45%. There is increase in the RBC mass also. Not only the water content increase, there is also an increase in the red blood cell mass. It is by 30%. Because this increase in the red blood cell mass is by 30% and plasma volume increase is by 45%. So as a net result, there is a condition of dilution in the blood which is known as hemodilution. Okay, because the cellular components, they increase only by the 30% and the watery component, the fluid component, increase by 45%. So as a result, in pregnancy the blood is diluted. So it's a state of pregnancy is a state of hemodilution. Because the RBC mass has increased, so there is increase in the RBC in the oxygen carrying capacity by 25%. We all know RBCs, red blood cells, they carry the oxygen, right? So the increase in oxygen carrying capacity is also by 25%. In pregnancy, all the clotting factors increase. That is why pregnancy is known as a state of hypercoagulability. Okay, the increase in the clotting factor, there is all the clotting factors increase except 11 and 13. That was a question of INICT May 2022. Okay, all the factors increase except, and answer was that 11. Okay, all the factors they increase in the pregnancy except 11 and 13. And because the fibrinogen is also one of the clotting factors which increases, and this factor is responsible for increasing the ESR, erythrocyte sedimentation rate, right? So a pregnant lady always have increased ESR because in pregnancy the fibrinogen increases, clotting factor fibrinogen increases, so the ESR increases. Okay, and this was a question of FMGE 2021. Okay, so there is also an increase in the total protein amount. The total protein amount increases, but because due to the increase in the blood volume, increase in the water retention, the protein concentration it decreases. So pregnancy is a case of hypoproteinemia, but the total protein amount it increases. There is increase in the TLC because immunity itself is suppressed in the pregnancy, and there is increase in the total iron binding capacity because there is a physiological anemia due to the hemodilution phase, and and that is why their iron binding capacity increases. That we know. Whenever there is a anemia state, the total iron binding capacity it increases. Increase in the humoral immunity. Basically there are two type of immunity, cell mediated and humoral. Cell mediated immunity it decrease in the pregnancy, and humoral immunity it increase in the pregnancy. Okay, so what are the values which decrease? Now in the first slide we have all the things which increase. Now we have the values which decrease. Let's see. HB decreases in the pregnancy. The value, the criteria to say that this patient is anemic is HB less than 11, which is very less than the normal patient. Okay, so if the HB is less than 11, then only we will say it a patient is anemic, because hemodilution is there. Hematocrit, if it is less than 33%, then only we will say that it is pregnancy anemia. Platelet decreases to 1 lakh. Platelet decreases to 1 lakh. Okay, so pregnancy is a state of thrombocytopenia. If 1 lakh से कम होंगी values, then only we will say it is a patient is thrombocytopenic. Serum iron and serum ferritin concentration, both of these decreases in pregnancy due to the hemodilution. Plasma protein concentration decreases, causing hypoproteinemia and leading to physiological edema in the pregnancy. What happens to the endocrinology, the hormones in the pregnancy? The thyroid and the other hormones. So, okay, first of all, let's discuss about the thyroid hormone. We all know that in pregnancy, the blastocyst has a layer around it which is known as trophoblast. Blastocyst, the embryo layer, has a layer, and this is the inner cell mass. This outer layer is known as the trophoblast. Trophoblast. Okay, this outer layer trophoblast has two type of cells, cytotrophoblast and syncytiotrophoblast. Okay, this syncytiotrophoblast, it secretes the HCG, and the structure of the HCG and the luteinizing hormone is same, and so the corpus luteum, thinking that this HCG is luteinizing hormone, it secretes progesterone and maintains the pregnancy. As the structure of the HCG is similar as luteinizing hormone, so the structure of the HCG is also similar to the thyroid stimulating hormone. So this HCG, it stimulates the thyroid glands and releases the thyroid hormone or T4, and due to the increased T4 level, there is suppression of the release of the TSH. Okay, because HCG simulates the thyroid stimulating hormone, so it leads to the increased production of the T4, and due to the increased production of the T4, there is a negative feedback and TSH decreases. So in the first trimester, the normal value of the TSH is 2.5. If it is more than 2.5, then it is considered abnormal. In second and third trimester, the second and third trimester, thyroid hormone binding globulin, it increases. So the more T4, the increased T4 which was there in the first trimester, it gets bind with the thyroid hormone binding globulin. Now as a result, free T3 and T4 it normalizes, and there is only a slight decrease in the TSH. Okay, so in the second and the third trimester, the normal value of the TSH is 3. Basal metabolic rate, it increases by 35%. Basal metabolic rate, it increases by 35%. Okay, because the body has to do a lot of functions. Okay, fetus synthesis its own thyroid after 12 weeks. So before 12 weeks, the fetus is dependent on the mother thyroid hormone. Okay, serum prolactin. In the starting of the pregnancy only, the breast starts synthesizing its ducts, milk. So the serum prolactin level, it increases, and it increases proportionate to the period of gestation. Okay, so what are the changes, physiological changes which one sees in uterus, cervix and the vagina? Let's see. Uterus and the cervix, they undergo hypertrophy and hyperplasia. Okay, because uterus has to carry the fetus, the growing fetus. So uterus undergoes hypertrophy and hyperplasia so that the uterus and cervix, they can carry the fetus. Okay, the uterus and cervix, uterus becomes more muscular. Okay, uterus, cervix and vagina, they get soft. So why they get soft? First of all, because there is uterus, because there is water retention. We studied during the hematological changes that there is a lot of water retention, and moreover now they are rapidly dividing. There is hypertrophy and hyperplasia. Okay, so these organs, they get soft, and there is increased blood supply, because once the organ has to undergo hypertrophy and hyperplasia, they need increase in blood. So nature provides that blood by increasing the blood supply. Okay, there is increased pulsation, that increased blood supply, which is almost 10 times. So that increased blood supply is felt as increased pulsations. Okay, and because of that increased vascularity, bluish tinge can be seen in these organs. Okay, what are all the changes? Because these organs, they have to grow, there is increased vascularity, there is a bluish tinge seen in this organ, increased pulsatility, and they get soft. Okay, embryo is a foreign body. Because embryo is a foreign body, so uterus contracts as a foreign body reaction. Okay, due to the foreign body reaction, the uterus contracts. What is Hartmann and placental sign? Okay, because the embryo implants, so there is a implantation bleeding sometimes, not universally, mind it, not always. Sometimes there is implantation bleeding, and if that bleeding occurs on the day of the last menstrual period, okay, for example, if that bleeding occurs on the same day of the example, the pregnancy is occurred on so last menstrual period was 24th April, and on the 24th May UPT becomes positive, and on the same day mild bleeding occurs, then that sign is known as the placental sign. If the bleeding occurs, implantation bleeding occurs on the LMP, it's only a spotting. Okay, and if it occurs otherwise on other days, then it is known as the Hartmann sign. Okay, Hartmann and placental sign, you know now. What is Chadwick and Jacquemer sign? Chadwick and Jacquemer sign is bluish discoloration of the cervix and the vagina. Bluish discoloration of the cervix and the vagina. So C for color, C for Chadwick, and Jacquemer, Jetac colors are known as the Jacquemer. Okay, so that is how you will remember Chadwick and Jacquemer sign. Softening, cervix, it gets soft. Okay, cervix gets soft, and there is if isthmus gets soft, then that sign is known as Hagar. Okay, softening sign, if cervix gets soft, it is known as Goodale sign, and if isthmus gets soft, it is known as a Hagar sign. Okay, so what are the two softening signs? Goodale and Hagar. Okay, Goodale and Hagar. Okay, so good hanging is soft. Okay, so how we palpate this isthmus sign? Okay, by bimanually. These two fingers we put in the vagina and go in the posterior fornix, and we feel the isthmus, and two fingers we feel it by per abdomen, and these two fingers, they meet. Why they meet? Because isthmus has become soft. Okay, so this comes around 6 weeks. Chadwick and Jacquemer sign, they come around 6 weeks, and then they continue, and this implantation bleeding sign, it comes around 4 weeks, because implantation occurs at that time. Pulsation sign comes little late, Osiander sign, and it is felt during the PV in the lateral fornix. In the PV in the lateral fornix, Osiander sign. Okay, contraction sign in the Palmer sign is seen in the early pregnancy, because I told you pregnancy is embryo is a foreign body, so body responds by foreign body reaction by expelling that embryo. So contractions are there. Palmer sign is that contractions in the early pregnancy, and these contractions are not felt by the patient. These contractions are not felt by the patient. And Braxton hat trick is contraction that occurs at 16 to 18 weeks, and this contraction can be easily felt by the patient. Okay. Now how you will remember that pulsation sign is known as the Osiander sign. Osiander is somewhat related to the word dhadkan. So dhadkan, Osiander. So that is pulsation felt in the lateral fornix during the pervaginal sign, and that comes very late around the 8th week. Okay. So what are the changes in the breast and the skin? Is already told by me that breast prepares itself for the lactation. So ducts they undergo, ducts and the alveolar glands they undergo hyperplasia. Ducts undergoes hyperplasia under the effect of the estrogen, and alveolar glands they undergo hyperplasia due to the progesterone. Okay, and increased prolactin synthesis is there in the whole pregnancy. As the period of the gestation advances, the prolactin increases and breast is preparing the milk in the whole pregnancy. The skin changes, the skin of the abdomen they get dark. In the center there is a linea nigra, and in the later pregnancy there is a stria gravidarum, and these both signs are due to the increase in the melanocyte stimulating hormone. What are the changes we felt in the cardiovascular system which are normal? One is that cardiac output increases around the, start increasing around the 5th week of the pregnancy. So as already studied, there is increase in the plasma volume by 45%. Increase in the that plasma volume has to be pumped, so the cardiac output also increases. We all know that cardiac output is equals to heart rate into stroke volume. So cardiac output it start increasing, heart rate also increase, stroke volume sometime increase, sometime decrease, but these two factors, cardiac output and heart rate, they both increase a lot, and the increase starts in the 5th week. And during the antenatal period, the maximum increase is around the 32 week. Okay, thereby the plasma volume it decreases a bit, and the cardiac output it is maximum around the 32 weeks. Then the increase is much more during the delivery in the intrapartum when the patient is delivering. Okay, and much more increases during the postpartum period. As these are the rates where the cardiac output is increased, more is the risk of the heart failure if the patient is suffering from any heart diseases. Okay, so in the postpartum there is increased risk, then in the intrapartum, and then around 32 weeks in antepartum. Okay, heart rate also increases. Now you all know that fetus grows in the uterus, and that uterus it lifts the diaphragm, so that is the why the heart is also lifted upwards and outwards. Okay, so heart moves upwards and outwards around the term. Okay, the apex beat is felt in the 4th intercostal space. All the heart sound due to the increase in the cardiac output are loud. The S1, S2, all the heart sounds are loud because of the increase in the cardiac output. S3 is commonly heard during the pregnancy, and that is perfectly normal. Okay, and systolic murmur is heard in 95% of the cases of the pregnancy. So these all changes are perfectly normal in the pregnancy. Let's study about the vascular resistance. You know that we discussed now only that there is increase in the cardiac increase in the plasma volume by 45%. Where does this all increased volume is there? Plasma volume increases by 45%. Where is this? This is in the capacitance vessel. That is their name. Capacitance vessels, they dilate, okay, and store this increased plasma volume. So they dilate due to the estrogen, progesterone, and nitric oxide. They are the vasodilators. Okay. So due to the dilatations of the capacitance vessels, there is decreased vascular resistance, and this decreases by the 35%. Okay, this decreases less in the later pregnancy. Early in the mid trimester there is significant decreases, and that is why, because there is decrease in the vascular resistance, decrease in the blood pressure in the pregnancy. That is why always the pregnant patients suffer from the syncope attacks. Okay, so and there is also supine hypotensive syndrome, because the pregnant uterus has large fetus which compresses the inferior vena cava when in the supine position. That is why always the pregnant lady is told to rest in a left lateral position so that the venous return is not affected. Okay, so let's see what are all the changes that occurs in the pregnancy in the kidney system. In the kidney, they also receive increased blood supply. Okay, that increased blood supply, increased renal blood supply, that leads to increase in the glomerular filtration rate, and this increased glomerular filtration rate lead to increased clearance. So glucose urea, protein urea up to some extent is normal in the pregnancy. The serum urine and serum creatinine, this both value, it decreases in the pregnancy because increase in the blood supply lead to increased glomerular filtration rate, and it lead to increased clearance of all the urine constituents. Respiratory changes. What are the respiratory changes? The fetus, it lifts the diaphragm, and as a result the lungs cannot expand maximum. So there is increase in all the residual capacities. In all the capacity where the residual volume is there, all those capacities they decrease, and because of progesterone stimulates the respiratory centers in the brain, so there is increase in the tidal volume and minute volume increases. There is no effect on the respiratory rate. So that's all about the physiological changes in the pregnancy. So let's see the question. All of the following may be observed in a normal pregnancy except fall in the serum iron concentration. Yes, there is a fall due to the hemodilution. Increase in serum iron binding capacity. Yes, whenever there is a fall in the serum iron concentration, there is increase in the serum iron binding capacity in the body. Increase in the blood viscosity. No, because this pregnancy is a state of hemodilution, so there is decrease in the blood viscosity. So this statement is wrong, and this is our answer. Okay, increase in the blood oxygen carrying capacity. Yes, there is increase in the blood oxygen carrying capacity by 25%. So these three are right and one is wrong. Thanks.
I hope you like this video. Please subscribe my channel, share this video to all the FMGE aspirants so that they too can get benefited from this. Thank you.